Hey, BC here for BC Nephro. I'm Dr. Brian Cronin, nephrologist and clinical specialist in hypertension. Today's topic, diagnosis of kidney stones. I'm not talking about diagnosing that a patient has a kidney stone, talking about for a patient with recurrent stones, diagnosing the type of stone and ruling out underlying secondary causes causing these stones to form. For more information, check out the other videos at this channel and bcnephro.com. A link will be in the description below. So let's get into it. I'm going to talk about the 5 main types of kidney stones. There are other kidney stones that are less common, but we'll talk about the 5 main types. So by far, the most common type of stone is calcium oxalate. This is followed by uric acid. Third is calcium phosphate. Fourth is struvite, which are infection stones. And fifth is cystine stones, the genetic condition cystinuria. Now, how to figure out which type of stone the patient has. This is important because knowing the type of stone really helps guide treatment, either dietary recommendations or medications. The best way to figure out which type of stone it is to have a kidney stone analysis. So get the stone, get it analyzed. Now the reports are going to give you often the chemical name, so I'm going to go through what the reports look like in real life. So first, for calcium oxalate. There's 2 types of calcium oxalate monohydrate and calcium oxalate dihydrate. Most stones are going to be a combination of the 2, and they even say that if it is solely one form, then you need to think about a potential genetic condition that's causing the stones. But most are a combination of the 2. What's the difference? Well, they say the calcium oxalate monohydrate is somewhat harder, so more difficult to break up with lithotripsy, and more likely to form when there is hyperoxaluria. Next, calcium phosphate. Calcium phosphate, in my experience, is most often seen in combination with the 2 forms of calcium oxalate. Often minor, but if it's a more major component, then you need to think about this as the predominant stone form. The chemical names of calcium phosphate that you most commonly will see is something called carbonate apatite. There also is hydroxyapatite and brushite. These are all different chemical forms of calcium phosphate. Next, uric acid. So the report, this will be pretty easy to determine. The report will either say uric acid or some sort of urate in it. The struvite stones are also called triple stones, and they're going to say something like magnesium ammonium phosphate or some other combination of multiple things. And cystine stones is going to be pretty straightforward as well. It's going to say cystine. Now, there are situations where you may not have the benefit of having a kidney stone analysis. There are certain clinical clues that may help you to determine which type of stone is most likely. Some stones are radiopaque, particularly calcium stones, and uric acid stones are radiolucent. The other types of stones, cystine and infection struvite stones, have some radioopacity. They're in between. Now, all types of stones are going to show up on a CT scan, which has the highest sensitivity, and all types of stones can show up on an ultrasound. Now, the ultrasound has a relatively poor sensitivity for finding stones, maybe about 50%. It does have a high sensitivity for finding hydronephrosis, but when we're talking about radiopaque or radiolucent, we're talking about an X-ray KUB. So if there's a stone, a calcification clearly seen on a KUB, then it's most likely a calcium type stone. If there's a large stone on other imaging, but nothing on the X-ray, then you're thinking about the possibility of uric acid. Now, for smaller size stones, the KUB X-ray is going to have a relatively low sensitivity, so you can't really depend on this to distinguish. Next, look at the urine pH. Some stones are more likely to form in a acidic urine, some in an alkaline urine. So if the uric acid stones form in an acidic urine, so the urine pH should be less than 5.5. If the urine pH is consistently greater than 6, uric acid stones are unlikely. If the urine pH is super high, like 7.5 or 8, then you're thinking about the infection-related struvite, magnesium ammonium phosphate type stones. Calcium phosphate stones also form in more alkaline urine, typically pH greater than 6.3 to 6.5. Calcium oxalate stones are pH neutral. They can form across the range of pHs. The third thing you can do is look for crystals under urine microscopy. Now for me, there's 2 types of crystals that are relatively easy for me to see, and they're relatively characteristic. The calcium oxalate dihydrate crystals, which look like little envelopes, and the cystine crystals, which are octagonal, they look like stop signs. Those are pretty characteristic. It's more difficult for me to determine the different types of crystals, likely because there is a different range of crystals that can be seen. The calcium oxalate monohydrate crystals, characteristically, they say have a dumbbell shape. Uric acid crystals have a rhomboid shape. The infection stone crystals, they say look like coffin lids. And calcium phosphate crystals, they say look like stars or rosettes. I will find a link to pictures of the different crystals to put in the description below. Now, if you're finding this video informative, please share it with someone else who you think may benefit from the message. It's spreading it this way that helps me get the message across to more people. Now we know the type of stone. Most stones are somewhat idiopathic, some combination of polygenic, genetic factors, and or dietary factors contribute, but there are some important secondary causes of stones to rule out. For calcium stones, most things that cause hypercalcemia can also cause hypercalciuria. So you're going to want to look for hypercalcemia, and if it is present, rule out things like primary hyperparathyroidism, sarcoidosis, and vitamin D excess. Now, hydrochlorothiazide can cause hypercalcemia, but it causes hypocalciuria. It's a treatment for kidney stones, but an important thing to remember is this. Hydrochlorothiazide can unmask primary hyperparathyroidism. I personally saw a patient with mild hypercalcemia that was attributed to the thiazide diuretic who turned out to have primary hyperparathyroidism as a cause of kidney stones. The other thing when you're checking the PTH, I found that many patients have an elevated PTH but a normal calcium. The majority of these patients I find to be vitamin D deficient as opposed to having primary hyperparathyroidism, and treatment with vitamin D often normalizes the PTH. It is my belief that treatment with regular vitamin D, unless you're super therapeutic and getting to toxic levels, does not increase the risk of kidney stones or cause kidney stones, but active vitamin D calcitriol can, and I would avoid active vitamin D in these patients. For patients who say they need something for osteoporosis, I often recommend taking standard doses of vitamin D3. For vitamin D overview, check out my short. I'll link it in the description below. Now, for calcium oxalate stones, hyperoxaluria is also a risk factor. So hyperoxaluria, very high levels, greater than 100, can be from either primary hyperoxaluria, which is a genetic condition, or enteric hyperoxaluria. Enteric hyperoxaluria occurs when there is fat malabsorption, bile acid malabsorption due to bariatric surgery or bowel disease, and these things increase the absorption of dietary oxalate. I have a short on this, and we'll link that in the description below as well. Now, for calcium phosphate stones, since they precipitate with a higher urine pH, you're going to look for things that cause this, such as distal RTA. Distal RTA not only causes a higher urine pH, but also is associated with hypocitraturia and hypercalciuria, so you can have a combination of calcium oxalate and calcium phosphate stones. Now, I have not diagnosed personally a case of distal RTA this way. However, there are drugs that can induce an RTA, most commonly topiramate, Topamax, which is associated with calcium phosphate stones. So if you have a patient on this medication that has stones with any significant component of calcium phosphate, you should make every effort to see if you can get them off this medication. Now, they say incomplete distal RTA can be associated with stones. This is a little bit more difficult to diagnose because the serum bicarbonate is normal, but if a patient has a high urine pH and hypocitraturia, this is a possibility, and I would treat it like you would an RTA with potassium citrate. Moving on to uric acid stones. Uric acid stones precipitate in an alkaline urine pH less than 5.5. The way you get an alkaline urine pH is by eating a high animal protein diet. Metabolites of this cause urine acidity. Infection stones are associated with high urine pH and associated with urea splitting organisms, most commonly Klebsiella and Proteus. So you're looking for an underlying infection here. And cystine stones, cystinuria is an autosomal recessive condition that leads to kidney stones, usually recurrent and starting at a relatively young age in adolescence. So that's it. Thanks for watching. If you made it this far, you might as well hit like and subscribe. It only takes a few seconds and helps me get the message to more people. And until next time.